This is the start of our semester series for seminars for the Center for Health Services Research. We're pleased to have Jeff Talbert and several colleagues speaking today. Jeff is the director of the Institute for Biomedical Informatics and professor in the College of Medicine. His colleagues Alexandria Corbeau, Kelsey Karnick, and Tony Mangino will also be speaking today remotely. And I will hand it over to Jeff at this time. Let me also add, though, that we're recording this and we plan to post this on the Center for Health Services Research website for those persons who want to continue to refer to the materials or people who were not able to attend at this time. So, Jeff, thank you.
All right, welcome. I'm happy to be here today to talk about our data sources. And I'll just first say that the data we're going to talk about today is really kind of a combination of a lot of sources that we put together to do these data sources. Some of them are supported by internal medicine. Some of them are supported by the IBI, which is the research center that I direct. Some of them are supported by the CCTS. And what I'm going to show you is the access to most of this data we have set up through the CCTS services page. And so I really want to make this a talk that if you want to learn how to do this, you can really go to the web page, fill it out, and then go to the data sources and apply for it and get access to the data. And so as I'll show you, we have a lot of people that have used this data, and we hope to have a lot more that will use this data. All right, so the agenda, we're going to talk about accessing data through the CCTS. As I told you, we're going to look at first UK healthcare data. And we've got a couple of different ways to access UK healthcare data. And then we're going to look at market scan data, which I think what most people were interested in for today, because we have a lot of new market scan data that UK just acquired. And then a little bit on the Kentucky hospital discharge data. And then I'm going to have Alexandria from the IBI and the CCTS talk about working with market scan data. So some of the things that we've done to make it easier for users to access and use. And then the last piece, I want some of the folks in the Biostat Circle to come and talk about their involvement in using this data. And what Biostat Circle does is they're an add-on for certain units on campus that you can basically hire them to work with your faculty. And they're experts at using this data, and they can help you in terms of statistical support, design your study, conduct your study, and even write up and report your study. So they're great folks, and I love working with them. All right, so some IRB considerations first. So the CCTS has a blanket IRB approval to, and this applies to UK healthcare data specifically, but we have a blanket IRB approval that we can provide de-identified data and some limited data sets to researchers at UK. And so you don't have to have your own IRB to get some of this data. So if you come in and you want a data set of diabetics with COVID-19, and you want that de-identified in a format to do your analysis on, you don't need your own IRB. You can just come and ask for that data through the things I'm going to show you, and we'll pull that data set, extract it for you, and get it set up and you ready to use. If, however, you do, that's not enough, and you need to have some more information, then is a completely de-identified data set. And if you want to know, well, what does it mean to be completely de-identified? There are 17 factors that HIPAA says are the things that count as de-identified. If you meet all those, you're golden. If you don't meet all those, in some certain circumstances, we can still give you a limited use data set under that no IRB one. But mostly, if you need some of those factors that are in that list of 17 HIPAA identifiers, we would probably ask you to just get an IRB anyway. It's not a difficult thing to do. We can even help you with the IRB application if you have questions. And so then you're just covered no matter which way you go. And then my last note on here, some projects start out as de-identified, and then you sit down with your data and go, wow, I really wish I had this. And then when we add that in, then it becomes identified data or limited data, in which case you probably would need an IRB too. So I say this up front because a lot of times investigators, when we tell them that, then they get a little upset with us because, well, you told me I didn't have to have an IRB. And that's true in most cases, but just if you do, then again, don't worry. It's just part of the research process, and we can help you get that. All right, so this is a picture of the CCTS webpage. So if you just go CCTS UKY EDU, this is what it looks like. And to access this, first you have to be a member. So if you're not a member of the CTSA, you have to join. So that big button right at the top of there that says become a member, you click there, and it asks you basically for your name, email address, and department, and then you're registered. So it takes a whole total of about 30 seconds. And we do that because we're applying for renewal for our CTSA again next year. And one of the things we report is how many people use our services, how many users we have. So we like to collect that information. So that's it. We're not trying to monitor you or check up on you. We just need to know to follow up on our grant proposal. So become a member first. Once you're a member, then you can select on this little services tab. So services and resources. So you click the services and resources, and then that pulls up this page. And under services and resources, there's a lot of them. But if you scroll down on this page, you'll get to data extraction because you want data. And under data extraction, there's a whole big long list of things that we can provide you. And some of those are the ones I'm going to talk about today. There's a lot of other ones on here we're not going to talk about today because we just don't have time. But anyone that's interested in any of these data sets, please contact us. We'll walk you through the process and help you. The CCTS actually even has a program called the Data Navigator program that you can just click the Data Navigator and say, they'll get back with you. And then when they do, you tell them, I want to use a data source. Here's what it is. How do you help me do this? And we can walk you through as a handhold if you need that as well. If you know what you want and you want to go to UK Healthcare, you just click that little blue link there. It says Data Extraction UK Healthcare. And that pulls up this page. And so then request this service. And so then this says the CCTS. It tells you a little bit about what we do and who we are. And this data set a lot of times is used for prep to research, or if you're thinking about doing a study and you want to know, do we have enough patients at UK that have these conditions? Or you have a colleague at another university and they say, I'm interested in doing a clinical trial. We have these many patients here at UAB. How many do you guys have at UK? Can we do this study together? And you can come in here and get some information about, is there enough patients in our system to support that study? What do we have? We're mostly looking at inpatient, although there's some outpatient data as well. Again, the little note about the IRB. And then actually this says 1 million, but it's actually up to about 1.5 million lives now in the data set. And the dates start from 2004. And the date starts in 2004 because that's when we started collecting data electronically at UK. And so before 2004, we were on paper. And so I haven't done a study before 2004 to see what the paper looks like, but I know some people that have done that. I don't recommend it. And so what do we have in the system? So really everything that's recorded into the electronic medical record. And it doesn't say this on here, but I'll make this point. We switched to Epic a couple of years ago. And so the data after Epic is in one format. The data before Epic is another format. And there are things that Epic has that the other system before that, Allscripts, did not have. So if you want data that crosses that barrier between pre-Epic and post-Epic, it gets a little squirrely sometimes. So you just have to be real careful what you're asking for. And you may end up having some censored data in the pre-period and or the post-period, depending on what your data set looks like. But basically, you're getting things like demographics, financial classification, the type of services that were provided, the type of providers that provided the services, obviously diagnosis codes, ICD-9, if you're looking at before 2017, I think, ICD-10 after, medical procedures, and this would be basically, depending on what kind of procedures you're looking at, what we call CPT codes, lab tests, and there are a variety of lab tests, and this would be, standard lab test, combination lab test, groupings lab test, et cetera, medications received, visit details, and this would be things like length of service, again, service units, whether it was a weekend admission, lots and lots of different choices, and then vital signs. And there's more than this. This is just a partial list. And I'll show you a way to access the data, and we'll look at some more details of that. But really, if you think about it, it's anything that's captured at the point of care by our electronic system is in that system for you to use. I don't have note data listed here. And so there's lots of different notes data that's captured in our electronic medical record systems. That is a whole research project in itself to get notes data. We hope one day it's not that way. But if you need notes data, talk to us and we can help you do that. It's just not a simple process. All right, one of the things we do have that makes it very simple for you to use is a tool called I2B2 and Trinetics. So I2B2 is a tool that was created as part of the CTSA program back around 2011 or so. And what it is, it's a simple web browser that we load our data into, our de-identified data set into, and we give anybody that wants it access to it. And so I say anybody, you have to have a Link Blue ID. But if you have a Link Blue ID, I'm on the right-hand side of my screen here. This is what, back to that CCTS web page view. If you click that thing of request an I2B account, it will create an account for you. And it's pretty much instant. It creates the account, gives it to you, and you can log in. You log in with your Link Blue ID. And so what this enables you to do is to run these little queries to say, how many patients at UK have diabetes? And it'll give you that answer immediately. You don't need to ask anybody. You don't need to ask us. You just do it yourself. So it's a self-service tool. The Trinetics tool is another system that we have that uses the same data in our I2B2 server, but it layers a web interface on top of it that this company called Trinetics has developed. And what Trinetics does is they give us an appliance that runs in our data center, and it runs this layer, but it also serves up for all pharma companies that pay them money. And the pharma companies get to look at our data as well to say, I want to do a clinical trial on COVID and diabetes. And then they would say, well, let's go see who in the network has enough data to do this with. And they'll run this query on their own and get the results. And if they see that UK has enough patients, they'll call us and say, hey, UK, we want to know if you want to participate in a trial. And we get, many of these calls every month. And what we then do is say, oh, you want a diabetes trial and COVID? Well, we're going to call Dr. Fisher and Endo and see if there's anybody that wants to be the PI, because we have to have a PI to be to lead a study. We can't just give our data out for a pharma company that's without anybody here overseeing it. So that's what happens. And if you're one of these people that might get calls from us saying, hey, we've got a company that wants to do a study with us, we're looking for a PI, can you help us? And again, we mostly call division chiefs and chairs to ask for those things, depending on what the trial is. But I'll show you some examples of what I2B2 looks like and then Trinetics. And so one of the reasons we have Trinetics is because we want to be part of that network so that we can get those relationships with those pharma companies. But the other reason is the Trinetics interface is easier to use, and it's got a bunch of features that I2B2 doesn't have. So this is what I2B2 looks like. I apologize for it being small. It's small on your screen when you put it on your computer too. You're gonna have to zoom in to see it. But what it does is this is what it looks like immediately after you log in. In the upper left-hand corner, these are all the fields that you can search on. And so those fields are that you can see here are diagnoses. And I've got the diagnoses field popped open because I have selected F11.1, which is opioid abuse, which is I do a lot of work in opioid use disorder. And so this is my example. I'm showing you what it looks like. So basically all you do is reach over and grab that field, drop it in the center part where you see this group 1, group 2, and group 3 here. And you'll see it says now F11.1 opioid abuse in that middle field. Hit the little run button, and it takes about 2 or 3 seconds, and it'll say 8431. And what that means is, and it says plus or minus 3. So every time you run this query, you'll get a different answer. And the reason it does that is because part of the way we make it available to anyone to use is it adds a plus or minus 3 to every query it does, so that if you're trying to run a bunch of queries and determine who somebody is, I don't know how you would ever do this, but because of that reason, it puts a little bit of noise in every query so that you can't drill down and figure out who a person is that has a rare condition or whatever it would be. So this gives you that choice to tell you there's 8,000 people. You can build as many inclusion-exclusion criteria into I2B2 as a clinical trial would have. So yes.
Obviously, you're talking about but if you put enough things in,
it won't report less than 10. Yeah, and it'll just tell you not enough patients. For the same reason, we just don't want you to be able to figure out, who somebody is.
what time period?
Great question. Thank you. People will think I paid you money for that. So my next slide says it's any time period because I didn't specify it. But you'll see what I did in there under F11.1. Now I've got 11/1/2020 to 12/31/21. So I put a time period in there and it cut the number in half. So now it's 4,100, basically. But that just gives you an idea of what you could do. But I mean, you could really take your entire inclusion exclusion criteria, put it all in here, hit a button, and it'll tell you how many we got. And that way you will know exactly, is it worth doing this study or not? And based on your experience. And so then you need no one's help to do this. You can do this all on your own. or your study coordinator or study team that you have, or your biostat circle person who works with you can do this and get it to you instantly. I mean, this doesn't take a long time. Yeah.
About the identified data.
Yes.
Let's say now we narrowed it down to, well, not 4,000, but let's say you got to 100 people. But now you want to identify them.
Yep.
Like, how do I find out who they are? It's
Perfect.
Not this program.
So if you wanted to do that, two things really. You can contact us and give us your query, and your query actually saves who's in there. And we can go back and find the query you ran, and we can find all the identified people of that you had in your cohort. Now, to do that, if you want identified data from that, you got to have an IRB. But if you did have an IRB for a study or whatever you wanted to do, we could get that data set for you. Yep.
That's the thing I want to make sure. So you got the number. It's de-identified. We can contact and you can download all of the de-identified stuff for us.
Or the identified stuff. Yeah, depending on if you have an IRB or not.
Right.
Yes, absolutely. Yep.
You got an IRB.
Correct. Yep, that's right. And this is pretty easy to do. And it was pretty revolutionary. We've been doing it for about 10 years, honestly. So hopefully everybody has heard of I2B2 before and knew about it. But if not, then here it is. And so this is a little view, and it might not look that impressive, but I'll show you a couple more pages of it. This is Trinetics. So this is a Trinetic version of the exact same thing I just showed you. So if you like I2B2 and you're comfortable with it, you never have to use Trinetics. But if you are interested in what the other interface looks like, it's a more modern kind of web design interface. And so this one, these are just all the queries that I've ran. So this is my account that I logged into today. And again, to log into this, you go to that little page on the CCTS form and say, right under I2B2, it says, I want a Trinetics account. Click that button, we give you a Trinetics account, and you log in with your link blue ID. So it's the same password. And so these are all the queries I've run. The one I'm going to show you is the one on top, which is the diabetes query. And so Trinetics also is part of a different network. We're in a network that's called the Southeast Network of Universities. And so that's with UAB, MUSC, and University of Arkansas. So you can actually query all their data right in here too, just like I'm querying UK's data. And in fact, you can see this number of diabetes says we have 341,370 in that network. And I'm looking at, actually, I'm going to look at UK and UAB at this particular point in time. But you could select which ones you want to run it on. If you just want UK, it's the same thing I just showed you in I2B2. If you wanted to run this query on the whole network, you can look at that network. I don't think it lets you run it on the others individually, but it might. I think it wants you to do it as part of the network. The other thing it'll do, there it shows you all the different pieces of the network. So the whole Southeast Shrine, 5.7 million patients total. UAB and UKY, 2.9 million patients total. UKY and MUSC, 3.4 million. And then these are some Trinetics things that we actually don't belong to, but there's this EMEA collaborative network, 19 million. That is Europe. So lots of different facilities across Europe. If we paid money to them, that we could have access to this data to use for things. Global Network Collaborative, 154 million people. And LATM, this is Latin America, 31 million. And then the bottom one is University of Kentucky, 1.49 million patients. So again, depending on if you're going to do a clinical trial in South America, you may be interested in this, and we can put you in contact with Trinetics and probably work out a way where you can use the data and find out patients that you might be interested in working with. The other thing it does is on this left-hand side, once I have a cohort, then I can click on Explore Cohort, and it runs a bunch of pre-defined features. And so this one is just looking at demographics, where it shows you kind of a little chart there of what are the age and years of people, male, female, different ethnicities, different race. You could also then click on the diagnoses, the oncology, if there's oncology data for that cohort, any procedures, medications, labs, and genomics, if there's genomics values on your cohort that you've developed. So all that is value-added things that Trinetics does that I2B2 doesn't. So we could have a whole day on just training for Trinetics. In fact, I've had a whole day of training on Trinetics, and it's really powerful, but we're not doing that today. I'm just showing you that it exists, and if you're interested, I encourage you to go and get that training. There's also some training on I2B2 that helps you use that as well for yourself. All right. I'm going to move on to market scan. So I'm back to that same web page that said, here's at the top, you'll see where the UK healthcare data was. Now I'm back to Truven Health Analytics. And we still have the name Truven on there. It used to be called Truven. So this data set has changed hands several times. It was Truven Analytics 10 or so years ago. IBM bought it from Truven, and then IBM just sold it 2 years ago to Merative. So now it's actually called Merative Market Scan. But they've kept the Market Scan name because that's really what it means. And so if you use it, then I would encourage everyone to refer to it as Market Scan, because who knows who's going to own it next year. It could be somebody else that owns it. But that's what this data set is. So what's in it? Well, we've had this data set for about 15 years at UK. And in fact, it started when I was in the College of Pharmacy that we started purchasing this data set. And back then, all we had was the top line, which is commercial and Medicare standard edition databases. And so that, as I'll show you in a minute, what that includes, but that's basically people with commercial insurance and people that have Medicare supplemental insurance. So not fee-for-service Medicare, but Medicare through an MCO type provider. Well, this past year, after Merative purchased the data set from IBM, they changed the packages and they started offering what they call the Atlas package, which is basically every data set that Merative has in their collection. And so that includes not only the commercial Medicare like we've always had, but also a multi-state Medicaid database, a lab database, a mortality database, health and productivity management database, benefit plan design database, health risk assessment database, a dental data set, which we've never had before. And then we get interim updates on the Medicaid data 2 times a year, and we get quarterly updates on the regular data 4 times a year. Never had those updates before either. So usually it's once a year we got an update. Now we get quarterly updates on the data, as well as weights. And the weights are important if you want to look at data over time, because each year this data is different amounts of people in it. And so just to give you a little description of where it comes from, and I have another slide on this, but I'll do it here first. This data comes from the Merative company contracts with employers or states in the case of Medicaid, and they provide services for them. And as part of those services, they cut a deal that says, we can bundle your data and resell it, and I'm sure they get a discount in their services that are provided. And then that's why it exists. So each year they have different customers. So the data set consists of different people each year. So that's why it's a different sample. But as you'll see, the samples tend to be very large. So but it does change year to year. So just be aware of that. It's not the same every year. In this license we have now, we have 15 years of most of the data. All right, so the market scan research data set. So this is a slide that the company has given us several slides on. It's kind of their marketing literature, but it's pretty good for walking you through what's in here. So that's what we're using it for. So the overall data set has about 293 million people in it, and that's over the whole time period. It shrinks down quite greatly if you're looking for a particular point in time in a particular disease set. But the data comes from about 120 employers for the commercial data. So again, that's those people, those employers contracted with this company to do services. And those companies are not, mom and pop stop down the street. These are companies like General Electric, really large Fortune 500 companies that have lots and lots of employees in multiple states. And so that's why you're getting 120 employers works out to be millions of people that are covered. That represents, which is kind of a neat thing, represents over 40 health plans. So if you're doing research that want to know, do factors about a person's health plan make a difference in their health? Like, do they have different copays? Do they have different co-insurance requirements? You can study that because there's about 40 different health plans in here. And in fact, we've had people do that, and it does look like that. It makes a difference on some of your health outcomes. For the Medicaid data, it covers it says 7 to 12 states. And so depending on the year you look at, it could have 12 states, it could have 7 states, it could have 10 states. And again, the data for Medicaid comes from Medicaid managed care data. So like in Kentucky, we have 5 Medicaid managed care organizations in Kentucky, WellCare, Humana, and on and on. So those companies would then contract with this Merative company to provide services. They get that data. When those companies don't contract with them, they don't have their data. So that's where the data comes from. And then the clinical variables really are all the data, combinations of all the data sets combined. So when you look at what the data includes, you get things like who's eligible for services, the claims information. So these are bills, right? These aren't electronic medical records like the UK data I showed you. These are claims data. So this is anything that's paid for in the healthcare system is in here. So if you pay for a visit to your provider, your doctor, that's in here. If you pay for hospital stay, that's in here. If you pay for durable medical equipment, that's in here. If you pay for pharmaceuticals, outpatient pharmaceuticals are in here. Inpatient pharmaceuticals aren't in here because those are bundled as part of a hospital claim. Benefit information, discharges from a facility, the productivity measures, the health assessment data, and I'll go into more detail about what those are. So what do they do to the data when they get it? So that's what this data preparation means. So they standardize the data across the different plans because all those plans have different vendors and the data is a little bit different. They link the data so that you can tell a person ID in one data set all the way through anywhere that person's ID gets care is in there. And that's important for doing longitudinal studies. It includes privacy protections. And this data set supposedly is HIPAA compatible. At least the company says it is. UK makes this treated like it's a limited use data set, although the company doesn't. And so just talk a little bit about some of the data. The commercial data is under 65 working population plus their dependents. So you think about a person that has insurance that works for General Electric and they have 3 children. So that whole family, the whole 5-person family would be covered in here. And you could tell who the siblings were. You could tell who the parents were of the siblings to do studies that you might be interested in. The Medicare data are retirees that are covered by previous employers. So like I work for the University of Kentucky. When I retire, at some point I'll get Medicare. And then that Medicare is part of my affiliation with UK. So it'll be a special version of Medicare that I can apply for. Those are the kind of Medicare folks that are in here, right? Not someone that's in the fee-for-service Medicare program. And then the multi-state Medicaid, these are just people that enroll in Medicaid and they happen to be in an MCO. If you're in Kentucky, we still have a fee-for-service Medicaid program. And that tends to be people that are in nursing homes or in waiver programs and they have some other special condition that prevents them from being in the regular Medicaid program. But if you're a regular Medicaid in Kentucky, you're in an MCO, right? So we've contracted that service out to those people to manage that care. That's the data that we have here. So just to give you some idea of the sizes, and this is only for the last, 5 years here as a sample. Commercial had 45 million lives, Medicare 2.6 million, Medicaid 18 million, 5.6 million lab values. And I'll talk more about the lab in a minute. We've used the lab value for a couple of studies. It's difficult to use. I'll leave it at that. Health and productivity management, 8 million lives, health risk assessment, 2.2 million, dental, 18 million, and benefit design, 45 million. And again, those numbers only cover that 2017 to 21 period. We have gone back for 15 years. So we have a little bit more data than that, depending on how big the earlier years were. This is just a little more information about each one of the data sets, and I'm going to go through this a little bit quickly. But the Medicaid one, basically, again, ranges from 7 to 12 states, is mostly made up of managed care plans. And this includes this similar data to what we have for the others: inpatient, outpatient, prescriptions, enrollment, long-term care.
We finished that one.
Okay. So just real quickly to repeat again. So under the Medicaid data, the interesting thing about Medicaid data here is that Medicaid does include race. And the other market scan data, if you've been using our market scan data for the commercial side, you'll notice that it does not have race. And so Medicaid does. Yes, UK healthcare does have race. Absolutely. As long as they put it. But we can't make them do it. But all right, lab database. So the lab database, 5.6 million here for lab patients among these years 18 to 22. The data elements that it include, the important thing here is a LOINC code. LOINC is a lab coding information system, much like an ICD-9 code or a CPT code is. It determines lab test. And so then you get lab results, reference range, if it's low, if it's high, you get the actual value and the dates that the service has happened. So the interesting part about the lab data is that the labs only covers when people get their services from certain laboratories. So if I'm a patient at UK Healthcare and I get my labs done in the hospital, that's probably done in-house at that hospital, and they don't send it out to a vendor. That's probably not going to get in here. This includes, they have a contract with the big lab vendors like LabCorp. So if you're at a remote clinic or some other site that sends the data out, then it's probably going to be in here. And so what we've seen looking at this data, even if I'm a patient that has some lab values, I may have other lab values that are different that aren't in there. So I like to think of it as it's a sample of that patient's lab values. It's not the universe of all their labs. And again, that may be good enough for you. We've just done a study with diabetes, and we were looking for A1C scores, and we did have some A1C values for these patients, which was nice because you don't get that in the other claims data. But again, I think it's just caution you to be careful that don't assume it's all the values. It's a sample of that patient's lab values, and it's not every patient. So under the data set we had, I believe it was about half, maybe half had lab values out of the people with diabetes in the system. So again, just depending on what your research question is, be careful with that one. The mortality data set, this is one that we've never had before, and it's an entire complete new set of the commercial insurance data, but it has their death in here, and it has some reasons for death, which we don't have in the other data set. And so the data set is a completely separate data set. So if you're running things in the regular market scan commercial data, you can't just flip over and see the same patients with the same ID number. They're different IDs because they having this information gives you more information that would make it not be the identified data set. So they have to report it this way. So if you have a need for mortality data, and we've had lots of studies where we've tried to do for cancer, where we're looking at cancer treatments, and we would just look at how many sessions that someone had of a particular medication. When they stopped those sessions, we assumed that they died or had a bad outcome, but we don't know. And so with this data set, you could actually see, did they actually die or just quit taking the medicine, right? So that would have helped a lot for our particular study that we were doing for that student's dissertation. But anyway, so that's a different data set. That's a new one for us. This health productivity data set is entirely new. We've never had this before. And this is kind of interesting. I haven't quite decided what I want to do with it myself yet, but it does have things like, it has a patient's age, gender, all the things that you might think about, what kind of employment class they're in. So relationship to their employee, if they're the child or the spouse. It has absenteeism, so how much work that they've missed. It has short-term disability in case they have used short-term disability. It has workers' comp if they've ever been in the workers' compensation system before for an injury. And then it has some payments for each one of those things. So again, I think the big one here is looking at the absenteeism. So if you're interested in that people who missed a lot of work, what kind of health conditions do they have? That would be a study you could do with this. So kind of interesting, again, a new one for us. This benefit plan design database is also a new one. So this allows us to look at some co-pays, co-insurance, and we had some of that data before. This is a little bit more information about what those plans look like. Spending limits, out-of-pocket, and out-of-network claims, which we didn't get before. So it will allow you to evaluate things like the impact of health plan features on health utilization. We've got a study we're doing right now on looking at patients that switch from regular type insurance to high deductible insurance, and then how do they change their behavior? And we didn't have this data, and so we couldn't use these, but we're going to go back and use these data on that particular study to give us a little bit more information about that. So that's kind of nice. Health risk assessment database. So here we get about 2.2 million people. So this is a little bit smaller data set than some of the others, but it allows us to get biometric information. So height, weight, body mass index, cholesterol, HDL, LDL, glucose, and blood pressure. So again, a lot of the stuff that we would like for health risk assessments. It looks at some health behaviors like smoking status, alcohol consumption, sleeping habits, dietary habits, exercise, seatbelt use, fire prevention. And then it looks at intent to change behavior around some of those smoking, exercise, diet, et cetera. And then some self-assessed health measures like physical health, mental health, and work absence. So again, a small number of patients, but this data can now be linked back to that other data. So you can look and see how someone says, I don't sleep well, I have sleep apnea, whatever it is. You could link that back to what other health conditions do they have? Do they have more AFib? Do they have, other conditions related to some of these measures that we just couldn't get before? So this is survey data collected from the actual recipient, and then we could link it back to their health outcomes and health behavior from the other data sets. So that's the neat thing here. Dental database, this is pretty self-explanatory, but basically it includes the ADA dental procedure coding for the same patients. And so if you were interested in, I know a lot of my dental colleagues in the College of Dentistry are interested in using this data. It allows you to link the physical health with the dental health data. So you can see what are the relationships that poor dental health has on their physical health outcomes. You can do that with this data set because it links back. And then just some overall notes about MarketScan, and we're going to make these slides available, obviously the recording, and we'll make the slide deck available on the center's website as well. And you can call us and we'll send it to you also. But this just talks about just kind of four corners of the data set here, what it's good at, what costs are in there. I didn't really mention cost yet, but it does have cost data for most of the claims. So if you were interested in the kind of cost benefit study of different procedures, drugs, outcomes, you can do that. That data is in here as well. And just to give you some examples, I had produced this a year or two ago on just a bunch of papers that we've published with this. We publish a lot of papers with this data set here at UK. And then I just thought, well, why don't I just go to PubMed and type in MarketScan at University of Kentucky, and it pops up 72 results. And I know there's more than that, but this is just a crude way to search. But I encourage you, if you're interested in using this data set, just go to PubMed and do MarketScan and then diabetes. And you'll see all the studies that have been done with MarketScan and diabetes, or everywhere else, whatever other disease state you're interested in. But there's a lot of papers that we've done. All right, this last one I want to get to, and then I'll turn it over to my other colleagues here. I'm not leaving them much time, is extraction with the hospital discharge data. And so lucky here, I only have one slide on this. And so we get this data set, and I bring it up because it's an easy data set to use. If you're a student, if you're a resident or a fellow, and you want to have a quick project that doesn't take you 6 months to do in claims, getting your hands all in the claims and having a rough time, this data set comes from the Kentucky Hospital Association, and they collect all the inpatient and outpatient discharges from every hospital in Kentucky. They assemble that data set at the discharge level, so not individuals, but discharges, and they submit that to the state. The state lets us purchase it from them for a small fee every year. And we've got that data from about 2000 to present. And so it actually has the hospital in there. So you could look at the specific hospital, and you can look at the zip code of the patient who went to that hospital, which is a cool feature you can't do anywhere else. But again, it's only the discharge. And so it's not claims, it's easy to work with. It's one row in the data set per discharge. And so you might say, well, what could you use that for? So here's a couple of papers that these are both my students that have used. And we were looking at birth outcomes because at the discharge level, and the data is by quarters. So no one can have more than one baby in a quarter. So there's not a member ID here, right? So you have to be creative in how you search this data. So we're looking at birth outcomes, and we were able to look at neonatal abstinence syndrome patients in Kentucky and compare it to the national HCUP data, which is published on the AHRQ website. And so we ran similar queries locally and similar queries on the AHRQ, and we compared our rate to the national rate, and our rate was 7 times higher than the national rate, which was kind of interesting. And certain counties within Kentucky has a rate about 10 times higher than that 7 times rate. So there's a lot of disparities in Kentucky in terms of birth outcomes. So again, this data can be used. And this was a student that one was published in the Journal of Rural Health, and one was published in JAMA Pediatrics. So, all right. So my last little note here is that we do ask if you use our data and you use a CTS form to do it, please cite us in your publications. You'll notice on all those sites on PubMed, it'll cite in there UL1TR001998. That's our CTSA number. You can also search by that number and get all the papers published by people that have been funded by the CTSA. So that's also very important for us to tracking and optimizing our renewal of our grant. All right, so next I'm going to turn it over to Alexandria.
question.
Yes.
Mention cost, talk about searching criteria cost. What is the cost to use these services?
Excellent question. There's currently not a cost to use these services right now. They're all free. They're all free. That may change in the future, but right now it's all free. So we encourage you to use it while you can. And the license we have for MarketScan right now is for 3 years. So it just started. So we encourage people to use it. And we're going to look at the end of 3 years, how much value are we getting out of this to determine whether we're going to renew it again. Because it is a considerable expense to license that data. All right, I'm going to turn it over to you, Alexandria.
Thank you very much.
And we can hear you just fine.
Excellent. So at least for people on Zoom, I have a slide deck here. I'm just going to go, so Jeff covered a lot of this already, so I'm going to go pretty quickly through some of these first slides. So we have quite a few years of data for a lot of these different data sets. You see commercial Medicare, that's what we've been calling Set A, or what Meritive at least calls Set A. That is the data set that's 2008 through actually September 2023. Right now, 2022 is our last full calendar year. That's why it's displaying that way. Set A, you can see which ones are Set A, which ones can be linked to each other that way. And I'll go into that a little bit more in detail soon. So this is just all what Meritive said that we were going to get. So we are delivered this data through a Snowflake cloud data warehouse. Instead of sending us files, they give us access to this cloud environment. Most of the stuff has been exported to a specific SQL server that we run on premises. And then we have normalized that, and I'll get into that a little bit later. But so we have two different databases, Truven with the kind of raw Truven data, and then TruveNorm, which has a normalized version that's easier to work with in SQL. You can get access to these two databases, and the Medicaid data is in there as well, and all that. But you can get access to these databases by entering a support ticket, which you could see on this first slide here. It's just support.cctsedc.uky.edu. And as long as you've completed all the requisite trainings, you can get access to those directly and work with them yourself, instead of putting in a request and having us pull a subset of the data for you. So this color-coded gives you a little bit more idea of what can be linked to what. So you see the green ones are all part of Set A in some capacity. They can be linked to each other on Enroll ID. And that, yeah, and so basically you can take the Medicare data or the commercial and Medicare data, link that to labs just to see how their diagnoses correspond to their lab values, for example, or whatever it is that you want to do. You can link on Enroll ID. The dental database is standalone. It does not link to Set A, just like the Medicaid database does not link to Set A. It is also standalone. There's an indicator in the Medicaid database if they are dual eligible for Medicare as well, but that does not link them to the commercial and Medicare Set A data. And then the mortality data is also standalone. It is not linkable to any of these other data sets. And we do not actually have this one loaded up because of there was some a discussion about how much it would get used because it does not link the rest of it, or linkable to the rest of it. So we don't have it loaded up locally, but you can request a Snowflake account and query it directly there. So you can still get access to it. We just don't have it loaded locally. Like Jeff mentioned, the commercial and Medicare data does not have race. but it does have region, state, and metro service area, and as well as age and age group. Medicaid does have race, but it doesn't have that location data. And we are working on getting the age calculated in as part of our normalization process, but it does not by default contain age. Now for the set A, this is just some really broad strokes numbers. Across all of our years, we have 191.6 million distinct enrollees in the commercial and 12.5 million in the Medicare portion of set A. Medicaid has 35.1 million. And you can see breakdowns by gender. The set A, like I said, we have through September 2023, from 2008 to September 2023. We have we have almost 200 billion days of eligibility across all of those people. Lots of them have at least 3 years of continuous eligibility. Quite a few have 5 years as well, 38.8 million. Over 1 million are continuously eligible the entire time. There are 10.3 billion unique diagnostic events, meaning a unique pairing of enroll ID and service date and diagnosis code. 12 billion unique services. We have lots of outpatient prescriptions that map to Metaspan, which is another licensed reference set for prescription data. There are about 1.5 million that do not map to Metaspan, but of those 1.4, almost 1.5 million have information available in a Red Book reference that accompanies the merit of prescription data. So you can map it back to an actual drug in the vast majority of cases. So again, in the set A in the set A world, you can look at lab values. These are just a couple of example queries where someone was looking at the average A1C value across different link codes there on the left, or different regions on the right. You can see the West apparently has a much higher average A1C in this data set than the Northeast, for example. Just interesting. So truth norm is kind of the meat and potatoes of what we've done. It makes it vastly easier to query. You can see on the right, you have to duplicate your work a whole lot if you just want to look at type 2 diabetes. You have to look in at least 4 different fields, and that's exclusively for out services. Inpatient services has way more diagnosis codes available. Whereas this normalized version, we take that wide data and it becomes short and long instead. As in, not very wide, but very long, and it's much easier to query in SQL. So you can see you're just looking at, you're not replicating your work. And that's why we tend to prefer truth norm over the default Truven data when we are doing data extracts for you. We also have a data dictionary for that we can provide you as well. Market scan is normalized by using a unique combination of enroll ID and service date. So we assign an encounter ID to that unique combination. We also do packed intervals for enrollment spans in the enroll ID detail table. Whenever something changes, it triggers a different span. So you'll see maybe they were enrolled for continuously for a long period of time, but one particular piece of data changed in that. And so you would have at least 2 different spans for that because something like their location changed, for example. Let's see. So this is an example of 3 different employees, or sorry, not employees, but enrollees who had eligibility from 1/1/2023 to 9/30/2023. And you can see we have this new surrogate key enroll ID detail ID, which gets included in the vast majority of our other tables because you want to be able to link easily to things like gender, or their other general eligibility information like their location and things like that. Let's see. The one piece to be very aware of is the diagnom field, the diagnosis number. It indicates which of those DX1, DX2, DX3, DX15, whatever field that the code came from. Just be aware that different procedures can have those diagnosis codes in different orders. So you can have the same enroll ID, but different diagnoms associated with the same code. That's just a quirk of MarketScan. We also link these diagnosis codes to CCS and Carlson categories. Just some other tables that we have in there. We have procedures, which is CPT codes like Jeff was saying before. We have Carlson and Elix-Hauser comorbidity indices calculated. Prescriptions are the outpatient prescriptions joined to the Metaspan data already. Lab results is just what it sounds like. The enroll ID year is continuous eligibility per year. So if they have 90% or more continuous eligibility for that calendar year, that will show up there as a yes. And then we have a summary schema in that database that has a bunch of aggregate statistics pre-computed for you. So if you just want to run some counts, they might already be there. And that was me speeding through that presentation. If you have any questions, feel free to put those in the chat, and I will turn this over to the next speaker.
Hi, everyone. My name is Kelsey, and I'm from the Biostat Circle. So I'm also going to try to speed through here so we have time for hopefully some questions, but we'll see. Okay, so like I said, my name is Kelsey Karnick. I'm here from the Biostat Circle, Biostatistics Consulting and Interdisciplinary Research Collaboration Lab. I think hopefully these slides will be made available afterwards so you can get some more information about us from the links. But who we are, so we're a group of biostatisticians who specialize in helping with the data analysis and some complex challenges of using this kind of interdisciplinary biomedical data and biomedical research. Our director is Dr. Emily Slade, and we operate in conjunction with the Department of Biostatistics and the Institute for Biomedical Informatics, with also support from the College of Medicine and the College of Public Health. So I dropped in some names here. I'm presenting today. My colleague Tony Mangino is also here, and a couple of circle members who also are going to get to know the MarketScan data are Christian McQuarrie and Will Cranford. So a little bit about what we do. So we assist collaborators in analyzing their data with this kind of biomedical and public health research. We're aiming to integrate ourselves into research teams. We're not a service corps. We're a little bit past consulting. So we would like to operate on collaboration and foster research partnerships with us, the biostatisticians, as team scientists into all of your groups using this data to answer your research questions. So it's kind of some of the information that Jeff was talking about. This is also funded by outside researchers, so individual researchers are not responsible for covering the cost of using a biostatistician. And this comes with a couple different methodologies. So collaborative unit projects on the left are current departments and units who the up tops pay for any researchers within their group to receive assistance. So you'll fill out a form associated with this collaboration link. A biostatistician will contact you and kind of start that collaboration. So these current collaborative units names are listed here. You can also see that as you go through our link process. Voucher projects are smaller statistical collaborations that are available for any researcher in the College of Medicine or College of Public Health faculty. Voucher-sized projects typically are shorter term and involve data analysis for a manuscript or statistical analysis plan for a grant proposal. Those you apply for and are based on availability and expertise with how one of our team members can assist with your project, and that's also through this link up here as well. Also for College of Medicine researchers and those within the College of Public Health, we offer 30-minute open consulting appointments based on first come, first served basis that are more short-term, quick statistical advice, no data is being traded hands, kind of an open consultation about statistical planning, methods, design, analysis, etc. So what assistance do we provide? So it's statistical analysis plans and perform analyses for manuscripts, unfunded pilot studies, etc. We help write and edit statistical methods. We can start all the way from study design, power analyses, grant preparation is also something that we can assist with. Just some keys to working and meeting with a biostatistician. The sooner you can meet with us, the better. We can work with you to look at data you've already pulled or are working with, or we can help you to design a study and pull the data. Some things to consider about your data set before you meet with us, your inclusion-exclusion criteria, how to create and will help you, or what is your patient population of interest, telling us about your project aims, research questions. Again, we are coming from the side of a biostatistician, but we would want to get to know everything about your project and your team, etc. So letting us know your research questions, and then your end project goals with abstracts, manuscripts, etc. Again, all of this and more information is available on our website. If you do not currently have a collaborative unit, but you're interested in providing this funding for your group, you can talk to Dr. Emily Slade or reach out to our overall email address. Here are those forms, and then again, some of the members, and then with the marketing data. Okay, that's my brief pitch. Thank you, guys.
All right. Well, thanks everyone for participating with us today. I think that's all we have for you. If we didn't get a chance to answer your questions, we're going to answer those and post them on the website for the center, along with the postings for the slide decks and the recording of the presentation as well. If you have any other questions, please feel free to reach out to us and we're happy to respond to you. Thank you all.